Hello everyone, my name is David Ward. I'm a research fellow with the Australian Frailty Network, and I'm very pleased to welcome everyone to our next Frailty Nexus Learning Link Up event, which is titled Gerontologic Biostatistics and Data Science, Creating a New Discipline, which is just such an enticing title for a presentation. And so we're extremely fortunate to have Professor Heather Allore presenting to us on this topic. Professor Allore is a professor of medicine and biostatistics at Yale University in Connecticut, and she's a leading expert in gerontologic biostats and geriatrics. She leads the data management and statistics core at the Yale Alzheimer's Disease Research Center and co-directs multiple other biostatistical cores that support aging and dementia research. Professor Allore founded the field of gerontologic biostatistics and has developed innovative analytic methods for studying trajectories of cognition, function, and mortality in older adults. Her work focuses on designing clinical trials and observational studies for complex geriatric conditions, including frailty and dementia, and addressing health disparities among older populations. So Professor Allore is happy to share these slides with anyone who might like a copy of these. Just send us an email at frailtynexus@uq.edu.au if you would like a copy. And just a quick note on questions, so please type them into the chat as they occur to you, and we'll have a few minutes to discuss at the end of the presentation. So that said, Heather, happy to hand it over to you.
Great. Well, thank you so much. I really look forward to sharing the work we've been doing. Oops, hang on one second. Oops. I'm getting used to this. Okay. So I always have to share what the funding is, and I have no conflicts of interest. This is the School of Medicine at Yale. So why don't we first start with what is gerontologic biostatistics? So it's a subdiscipline that is really designed around the study and development of statistical methods used for contemporary design and analysis of research data to really be able to look at that biomedical aspects of aging research, and especially in older populations. And this first part of the talk, I'm going to be sharing with you a bunch of resources that are free, and please avail yourself to them. The Gerontologic Biostatistics is now a subdiscipline of the American Statistical Association. It's free to join the statistics and data science in the aging interest group. We have monthly seminars and a number of different activities. So who created it? Well, basically there's this funding mechanism called the Claude Pepper Older Americans Independence Centers, and these are at a number of different universities in the US. But between Yale, Duke, and Wake Forest, you can see our photos here, a number of us put in a grant and started this field because we all were doing a lot of trials and aging studies. So we had our first paper quite a long time ago in 2010, where we introduced the discipline. And so this was really to kind of conceptualize where did gerontologic biostatistics fit within gerontology, within the medical discipline of geriatrics, and how did that overlap with our basic science understanding of aging? How does that fit with biostatistics, which is a subdiscipline of statistics? So why do we need this? Well, the world is getting older. And if we look at this little graphic here, we see in about 2034, it's estimated, at least in the US, that the number of older adults is going to be surpassing that of children under 18 years old. So we need to really be aware that our demographics are changing, and we're going to be studying more older adults. their health and aging conditions. And so this, the foundation of gerontologic biostatistics is to be training people, especially biostatisticians and gerontologists, on how to study complex older adults and their needs. And so when you're starting a discipline, you need to think of it in three ways. What is the theoretical foundation? What are practical elements? And where does this fit in kind of a social scheme? So there is something very distinctive about the gerontologic biostatistics because there is this multifactorial etiology of geriatric health syndromes, right? So there's many different elements. There are not only many health conditions, there's social conditions, there's living conditions, there's a number of different things that make it unique. So for a practical rationale, again, what are we trying to do? We're trying to provide and develop designs to be able to study things. And then from a design flows how you're going to analyze the data. And later in the talk, I'm going to be walking us through the evolution of a family of methods. And so you'll see how that evolves. But what are the classic things that we have happening with older adults? We have missingness that can be dropout due to incapacity, they have dementia, they're frail, they no longer can do tests, they move to residential care, they're no longer in the community, so in some studies won't follow them, they may be dying. This missingness could be informative. They may have to need proxy respondents, carers, family members, healthcare providers that are providing responses when they can no longer provide responses themselves. You often are looking at integration with qualitative data, mixed methods, to really try and inform the understanding of what these are. And you just have so much variability, which we term heterogeneity in health. You see 180-year-old, they can be fit, they can be active, and another is in palliative or hospice care. So there's a huge range in health and social abilities over the lifespan. So then last year, we updated Gerontologic Biostatistics and had a new article. And here we now have grown to include data science. And so just as now there's more advanced computing, newer biotechnologies, we now can incorporate, although today I won't talk very much about the basic science side of things, which is, we'll just briefly touch on geroscience, but there's a lot more in the omics world, phenotypic measures. We're doing much larger data with electronic health records. So you're seeing a lot of information, integration, and from that is flowing other techniques such as machine learning, and we have to have newer designs. So if we look at the forms of statistical modeling that's going to run this gamut from the side that's very statistical based through machine learning techniques, you can see there is some overlap, and I'm not going to spend a lot of time on this slide. I encourage you to read our article, which is going to give you a lot more detail, but we try and disentangle based on the increasing conceptual and computational complexity where you may want to start to look at to use different sort of analytic methods. And so these are all integrated into our conceptual models. So again, I'm trying to give you a lot of tools because there's no need to reinvent the wheel. So through this website at the National Coordinating Center for the Older Americans Independent Centers, we've put together the Geriatric Research Algorithms and Statistical Programs called GRASP. And this is, we'll well, I'll show you a couple examples so it'll make a little more sense. So we often put quite an investment into trying to develop new ways to be able to analyze data. So this is just one example, the longitudinal extension of an average attributable fraction, which we call LEAF. And so if you click on the link for LEAF, then you're going to find out a summary of what this is. And so this is, so many of you are going to know what an average attributable fraction is. But what happens when you have something that you have longitudinal data and you're having risk factors may come or go, and you're trying to say, how are these associated with outcomes, and often multiple outcomes at the same time. And so we have, what you have in this website is you're going to have that code. It's going to tell you the language the code's in. It's going to have instructions. It's going to often have like presentations, so you can follow and see how we develop things and how to use the software. You'll see here's another one, CR Coder, which is to be able to estimate marginal and personalized concomitant risk modeling. So that is, instead of, you may be familiar with competing risks, where one event precludes the observation and another. This is concomitant, so you can see two outcomes, two or more outcomes actually, at the same time. So maybe ADL disability and frailty status at the same time. And so most models are marginal or over the observation period, but by using the information in shared random intercepts, you can actually get personalized estimates. And so you can see, well, we give you code here, we give you citations where we've used that, but I'm just giving you a brief taste of the many different things that are from articles that we're the first to do these methods, and we want to make that code shareable and findable to other people. Then yesterday, I was fortunate enough to meet some PhD students and give a master class where we use the Geriatric Research Instrument Library, or GRIL, also at the same website. And in this, there's a number of instruments. So we can see frailty, cognition and dementia, a number of different domains. If we, here's the domain for cognition and dementia instruments, you can go through, it's going to this give you a brief overview of them. If you select a particular one, in this case, the Montreal Cognitive Assessment, called the MoCA, it's going to give you more information on it, a description, references, links, and other materials. So this is a very useful tool to help you planning your studies, pilot studies, observational studies, or clinical trials. Now, just as earlier we saw the kind of diagram of the range from statistical to machine learning models, just within longitudinal methods, there are many, many different choices. So we have a different article that I wrote with collaborators on a guide to select among many longitudinal models specifically focused on gerontologic biostatistics and those unique characteristics when studying older adults that may have missingness. You may want to look at multiple outcomes. And so in this article, there's a very nice decision guide to help you. Now, another resource I want to give you is through the American Geriatric Society, and that's our learning collaborative. And this is a comprehensive curriculum targeted for early career investigators interested in multiple chronic conditions. But I think that many of you might be interested in this because you're going to get a core curriculum where you can be using these for your teaching. You're going to have podcasts. You're going to have a whole curriculum developed here and an online community, which we continually add to. This fits in frailty just as well because we know with many examples, such as the clinical frailty scale, one of the decision points is how many chronic conditions does a person have when trying to gauge their level of frailty. This is an example of our learning collaborative, where you're going to have that online curriculum that can either be self-driven, so you can have do it yourself, you can have your students be doing it. If you're teaching, you can download slides, podcasts, you're going to have live and recorded webinars, and you can see there's a number of different curricular domains. And it's all free. You do have to register, but it's once you're registered, there's no cost to register, then you can access this. So these are major areas here. So those of you who are really interested in patients, family caregivers, other stakeholders, there's whole sections on how to do that. With Dave Rubin, I developed the research design side, so we'll take a look at that. So if you pick one of these topics, you're going to get a screen that's going to be saying, okay, these are the topics that are going to be discussed under each of these domains. You pick research designs, you're going to see our table of contents, the slides, the live communities, and then you pick one particular topic that you'd like to go into, and then you have that whole presentation that we've put together. And we do have leaders, we've selected leaders from around the world, and Emily Dressler's at Wake Forest University in the US. Another resource that's, again, free is the Impact Collaboratory, which is a group of over 30 different institutions in the United States that have put together materials and trainings and funding for people that want to do embedded pragmatic clinical trials for persons living with dementia and their care partners. And all of these interventions are non-pharmacologic. And so if you go to this website, then you're going to have access. So we're in our 6th year. You'd have access to grand rounds and podcasts for 6 years of information, many of them on design topics such as stepped wedge designs, dyadic designs. You're going to have a whole knowledge repository that links you to many different resources. There is a patient and caregiver reported outcome library that tells you all the elements of it's much like Grill, but it gives other information about validation and a number of different aspects, but it's very focused on patient and caregiver reported outcomes that you want to build in. And we have a number of training modules as well as engagement. You can ask questions through engagement. So there's many different things you can do there. I co-lead the Design and Statistics Core, and here's our members. We've had postdoctoral fellows. We have faculty scholars. That's an opportunity to work with us. Faculty scholars can be in many different countries. And our aim is really to provide guidance to investigators planning and conducting embedded pragmatic clinical trials for people living with dementia. We have been working for 6 years on developing a variety of new study designs, randomizations, analytic approaches. We have several very complex sample size calculations. I'll give you a link to those in a sec, just a slide or two. And so we're always looking at and developing novel approaches as well as how to do reproducible analyses and replication of studies. So study design is clearly a passion of mine, and I really do like this cartoon where these mice are saying it's rather interesting phenomena. Every time I press this lever, the postgraduate student breathes a sigh of relief. So over the 6 years, we have done lots of consultations, lots of building investigator capacity, and we have developed many different products. So all of those would be available to you. So what I'd like to really point out here is many of these design tools and software. So we have a variety of tools for how to estimate interclass correlations for outcomes of these sorts of studies, how to analyze dyadic data with hierarchical clustering. So there's a link there. You can see that's at our GRASP site. Multivariate designs for stepped wedge, cluster randomized trials. So that's where you're having multiple outcomes for these, and stepped wedge designs are a type of design where eventually each unit is exposed to the intervention over time. As I said, we do quite a few very complex designs for sample sizes through simulations of complex data structures. We also estimate and model heterogeneous treatment effects. And so that way you can say not just simply the overall effect, but is there a group with certain characteristics that especially benefits from the intervention that was conducted. So what else do we have at this Impact Collaboratory that we've been trying to share with people for a number of years is we are especially concerned about health disparities and vulnerable populations. So here we are with the Nexus Frailty. So you may be, these are frail people. People that may have limited access to health care or different things. So we have put together a whole set of guidance. Again, you're going to have a whole package of material that's all free. These are resources, publications, and I'm going to give you a couple examples here. So here are best practice sheets across a number of different domains when trying to plan these sorts of clinical trials. So remember, an embedded pragmatic clinical trial is trying to put a clinical trial in a healthcare setting or an residential care setting. So you're putting it into a real life. That's what pragmatic is. So you're embedding the intervention pragmatically into an actual working system. And so these are all guidance on how to do that. We also have a whole certificate program. This is, it gives you the whole background and rationale about doing embedded pragmatic clinical trials. It teaches you also about the working with vulnerable populations. You have, there's 6 different courses. Each of these elements in here are going to have 2 to 5 video modules. There's self-evaluation, there's glossaries, additional resources. So there's a lot for you to be able to learn, and you get a certificate at the end. I'm briefly just going to touch on geroscience. So that is looking at more of the basic research side, what underpins aging, how do we age? So there's a whole development of different sort of drugs, senolytics, semimorphics. How might we be trying to intervene on different aging processes? And so there's a couple different aspects of this when we think about how we do trials in geroscience. And so maybe we're going to test anti-aging therapeutics, and maybe it's that you have a single therapeutic and you're going to try and use that, and you're going to measure against multiple conditions, maybe in a series of trials. Maybe we can do this more efficiently in combination, or maybe we're going to be testing, helping people design to test for the effects against multiple geriatric conditions and diseases, but we remain agnostic to what those are. So that would be a different sort of design. So we are trying to also help investigators really think about how animal trials can help inform human trials. So if we're finding these mechanisms in mice, can that translate to the human condition? So this second part of our talk is going to really talk about the evolution of one class of methods. And way back in 2010, back when we started the field of gerontologic biostatistics, I was fortunate enough to work with Tom Gill, and we had a paper in the New England Journal of Medicine about trajectories of disability in the last year of life. And this paper was the first to ever use group-based trajectory, latent class trajectory modeling in medicine. And so it was motivated by the question of, if you knew the person's health condition, their disease status or their frailty status, cognitive status, would that give you insights into their disability in their last year of life? And so there hadn't been uniformity, and in this, certain people believe that a disease followed a specific course. But with Dr. Gill's Precipitating Events Project, we measured disability items every single month. We started with 754 people, and we followed them to the end of their life. And so we followed them many, many years. And what emerged was that there were four distinct trajectories, or there were five distinct trajectories in that last year of life. And when we looked at these trajectories according to the conditions leading to death, we'd see for people whose conditions leading to death was cancer, they didn't follow a single trajectory. There were different proportions of them. 20% had no disability in their last year of life. Over 30% had catastrophic disability. If we look at those with advanced dementia, well, okay, nearly 68% had persistently severe disability, but then many had much lower levels of disability. If we look at frailty, right, well, kind of the motivation of the whole Nexus frailty, we see that people are divided across these disability trajectories in the last year of life. So now I want to show you how this technique has evolved over many years. So I had a graduate student who was a cardiologist, Dr. Mori, and he was interested in pain after cardiac surgery. So he was very concerned about post-operative pain, which they wanted to control. And so just for his PhD project, we collected patients for about a year, and they had questionnaires every 3 days about pain around their incision site. And so then we used this group-based trajectory approach to study that outcome. So if we look at this slide and we look at the raw data, you'd say, well, there doesn't seem to be any pony in this picture. The pattern's all over the place. And then if we just did a means model, a single mean, what's the mean level of pain over these 30 days? Well, it's not really informative, right? It has this like giant confidence interval. and the mean is really not informative. But if we did when we do the group-based trajectory approach, we see that there really are distinctly different groups. And how long? So if you're in the persistently low, we know that really at day 3. If you're in the low declining, we know that at day 3. But it does take us to about day 10 to really be able to differentiate between people who start high and decline and those who are persistently high. So this is a way to help understand noisy data with that heterogeneity, that high variability, and to disentangle those trajectories. So then I was working with a geronc, so a oncologist who focuses on older adults, and she wanted to look at functional trajectories and really that resilience. Who is resilient after treatment for advanced non-small cell lung cancer? And so these are all older adults, and we're measuring their disability status with the Euroqual 5D, 5L. So we're going to use, again, this latent class trajectory. But these people are very ill. They're all older. They're all being treated for advanced lung cancer. And so we have to consider their attrition due to death or withdrawal. So here we can just see kind of the overall view. And so a posterior probability of assignment is the way we judge the fit of the model. So for those that would be on the basically the none is having no functional deficits. 95% of them fit that line very well. So you can see very tight confidence intervals around there. All of these are very good fits. That's just a model fit measure that we use. But you can then see, so that highest group, you'd say, well, boy, they really start to um, go up with their amount of disability and then decline, but that is basically a healthy survivor effect. So the right panel will see that dropout probability, which is dropout or death, and we'll see that unfortunately 72% of those with severe disability after their treatment for advanced lung cancer do not survive to 8 months. So then after we characterize people into these trajectories, then we can really look at what are factors that are associated with this, so we can have better insights to care for patients or predict outcomes. So if we just consider our patients in the severe disability, we can say what's associated with being with that. And so it's their ECOG performance score, having dyspnea and pain, having higher PHQ-9 and GAD-7 scores. And so we can say of our whole cohort at 8 months, about 46% displayed some resilience, so they could maintain their function. And then we can say about 5% had a functional decline, but over a third were deceased. So then we can really, when we're trying to explore things, we can see, well, is this a result of death or withdrawal? And we study this to see like what's happening. And now I'm going to give you yet another way that we apply these methods. So this is working with a Dutch colleague, Bianca Berman, and she wanted to look at trajectories of disability among older persons before and after a hospitalization, and that hospitalization led to a skilled nursing facility admission. That's like an age residential care is a skilled nursing facility in America. So here we do a similar approach of this group-based trajectory modeling, but we do it such that we do it, panel A, we look at before the hospitalization, what are their, in this case, the functional disabilities. These are ADLs and IADL, so basic activities of daily living and instrumental activities of daily living. And the B panel looks at after discharge to the skilled nursing facility, what are those trajectories? And panels A and B connect such that I kind of give an example just for one of them. For those with the minimal disability, that kind of purple line on the A panel, that lowest one, lowest disability, before the hospitalization and going to a nursing home, 52% had substantial improvement. So immediately after the hospitalization, they were higher, but they were able to drop down. But then we have about a third of them having little improvement. They actually seem worse to me. And 16% had no improvement. They're really at the top of our scale. So the article would go into all these different combinations. But then you'd say, well, maybe if they had rehabilitation, that this would kind of solve a lot of this. So then we can look at the combination of before the nursing home and during the nursing home, and those combinations of where they were at, the minimal to the levels of improvement, and then how much of this resource utilization group is essentially the number of minutes of rehab they get, and some other services. And so we can see this really unfortunate group of the people who were minimally disabled beforehand and had no improvement. They were maxed out. All of them got rehab. While you can see of those light blue bars for many of the other transitions, there's a certain proportion who had no rehab, but sometimes they had better outcomes. So this helps us understand some of these transitions between things, and was it able to be mitigated through rehab. Then we can say, okay, now we've got these combinations. How were you before and how were you after the hospitalization? And we can look at 30-day rehospitalization and mortality. And again, for our group of our minimally disabled that had no improvement, they have very high, the highest 30-day readmissions and the highest mortality. And so these there's a number of different things you can be doing with these. These are joint trajectories of these in this approach. So there should be some interest in our work in the joint trajectories of cognition and frailty. And then we estimate these together. So we can then create, basically it's a column, right? And we're going to look at, these were jointly estimated such that we can say about 28% of the individuals had no cognitive frailty. Their MMSE score was high. That's a measure of cognition. Their frailty score, this is the Linda Fried frailty, the 5-item, so that 0 is non-frail, 1 or 2 items is pre-frail, and 3 or more items is frail. And we can then see that there is a group that has a slow cognitive decline. This is over 108 months, and progressive frailty. But they're staying, their MMSE score, it always stays above a level of dementia, well above it. And then we have a group that has a rapid cognitive decline. About 20% of people fall into this. And they have very similar progression in frailty as a group that maintained, had a very small decline in cognition. And then we really have this about 6.5% of people really have this cognitive frail phenotype where they have this rapid decline in cognition. They start high. You can kind of see that they are having similar starting points in frailty, but they really go all the way up and max out over time. So then if we say, okay, what's their burden? What's associated with these? Hospitalizations look really similar, but boy, you're really seeing much higher cumulative rates of nursing home admissions. Really, it's really quite a dose response there. Real increases in ADL disability, huge increases in IADL disability where you're really maxing out. And then you can really see that mobility disability is increasing. So we can do this with another approach to look at mental and somatic multimorbidity. So this is a different data set, and I'm just going to leap over here to kind of orient you. So we want to figure out what's the predicted probability of cognitive impairment over time. And here we're going to look across an age group. And what we want to do is really be thinking about how different combinations of somatic or physical, and then in this case, we're going to be looking at stroke and depression are leading to these increased probabilities. And this approach is a little different because here we're looking at transitions at different age points. And so that is, in real life, we have diseases that develop at different times. And so that's where you see that jump in. So you're, say, at the top left, and we're looking at wherever you see that jump up, that's where you've now added that additional, in this case, stroke in the top left. And you see that really increases at age 60 for where you started on each of these curves. You can see the transitions at age 70 and 80, and you can see how we do this for different combinations of stroke, depressive symptoms, and then having them both. And so lots of times we really need to account for changes over time. What else can we do? I'm trying to make it harder and harder. This is just one technique that we've been developing. I really put a lot of work in over my career, but this is only one of many. You can look at multiple dimensions. So here we're looking at the number of chronic conditions, the ADL and IDL limitations, cognition, and depression. So if you think about what are a lot of the elements of the clinical frailty score, you're going to have, they're right there, right? It's your chronic conditions, it's your disability level. There's elements of cognition in there. There's depressive symptoms in there. So you look across these, and again, you work in a column here, and these are these phenotypes that emerge, and these are simultaneously estimated across these different measures. So I just wanted to give you this quick overview of how we developed gerontologic biostatistics. It's a team effort. I've worked with people not only across the US, but in Europe and Australia. And so everyone's welcome. We try and share all our resources. It's really becoming more and more relevant as the population ages. There's lots of tools. Please avail yourself to them, and keep calm and love biostatistics. And I'm going to leave you with this very, to me, inspiring photograph. This is Manette Bailey. She's 102, and she's preparing to skydive over England. Last I knew, she was the oldest woman who skydived over England. So, aging can be a really positive thing. And thank you so much.
That was really fantastic, Heather. Thank you. Extremely interesting, very useful presentation. I really love that simple example you provided about how that mortality-related dropout can affect those group trajectories. Just such an important point to make for people who are doing aging research, and as well as everything else. So that was fantastic. There's one question in the chat. I've got a question as well to kick us off. It's a bit of a selfish question. It's about frailty measurement, really. And my question is really about the sort of complexity of measuring frailty and vulnerability. The way we capture that in research settings is often quite different to how we measure it in clinical practice. In research settings, you can develop these extremely complicated models now of frailty and vulnerability. But in clinical practice, often people just want a quick test with a simple score to inform their practice. So any thoughts on how we bridge those two worlds?
Well, this research shows, as you can see, I was trying to, like with the pain, right? I was trying to say, okay, you can look at these curves and say, at what point can I differentiate these people and their future potential? And so for all these trajectories, you could say, you can use them in a predictive manner to say, okay, if someone was here, so either I knew things before they went to the hospital, right? And now they can't be discharged back to the community. They have to go to aged care, then what is it that I'm going to be able to start to differentiate these people, right? So you can use a lot of these things so that it's just a simple metric, right? And with a lot of electronic health records, we can be tracking things, and in the future, where these are going to be built in so that it gives, people always want to know what's going to happen to me, doctor. I had this thing happen, right? And so it really can help guide, right? And it can give us this information. What were the things that differentiated patients, say with the lung cancer, who did much better and those who didn't? Are there things that then they can say, you have a lot of dyspnea, we need to start looking into that because that's related to worse outcomes. So I think that there really is a way, and we do try and create these as practical and that can drive clinical conduct.
Thanks, Heather. So I've been asked to decide if this is a relevant question. The question asker is actually a professor of geriatric medicine, so I'll defer to them. But also, it's a very interesting question. So Vazi is interested in your views on the methods of analysis for the monoclonal antibody trials in Alzheimer's disease. He's interested in, the differences between comparing cognitive scores versus doing survival analysis of functional outcomes. In general, he's interested in whether there are any big picture lessons for drug trials in older adults.
Sure. Well, lecanemab, the senior author of that paper is Chris Van Dyke. I work with Chris at Yale. He's the co-PI of the Alzheimer's Disease Research Center, where I lead the statistics core. So I just want to tell everybody that so they could understand if there were any sort of biases. So of our amyloid-sparing therapies, there's 2 approved for use in the US. It's only for people who are very early in their course of cognitive decline, which is why there's so many tests for blood-based biomarkers that are going to the FDA right now. And so we know that of the people that have been exposed to these amyloid-sparing therapies, that it doesn't improve cognition, it slows decline. They have a risk of ARIA, a type of bleeding in the brain. And so there is a lot of research in other sort of factors, phosphorylated tau, a number of different factors that we're exploring. So it's an important area. I didn't really focus on the basic science work we do, but it is relevant.
Just to add to that, because we've got a couple more questions, minutes for questions. How do we sort of come to terms with the lack of representation of frail people in those trials, do you think?
Well, I think a lot has to do, so yeah, the US did change, and I was part of the committee years ago that the how the US government, the NIH, would fund clinical trials used to have very strict inclusion and exclusion criteria because they had heightened concerns about harming potential participants, which obviously we all care about. But then what we found was that now we were developing medications or surgical procedures or devices that were mostly being used in individuals who were never tested in the trials. So then we revised inclusion and exclusion criteria so we could better include vulnerable people, but have to have safeguards in place at the same time. So indeed, older research didn't have them because of basically our safety and regulatory environment, and that changed over time. But it's also very hard to recruit. The number one reason that clinical trials fail is because they don't meet recruitment. And so it's not that whatever the intervention is the failure, it's they can't recruit people. So it's just very, very hard to recruit frail and vulnerable older adults.
Thanks, Heather. I don't think there are any more questions, but everyone has typed lots of messages of thank you into the chat. So I think that was very well received. So yeah, once again, thank you very much, Heather, for joining us. It was a fantastic presentation.
Great. Well, I enjoyed it. Take care.
Bye.
Bye.
Bye.